X-ray. Okay, interpretation of the chest X-ray. The part one is what we are doing here. So what we have to understand is the basic physics, which we have already dealt with. Then the methods of obtaining chest X-ray. We have different views. What is an AP view? What is a PA view? And when do I say it? A lateral view. Okay, now the first thing is how a chest X-ray works. So this is how it works. Now there is an X-ray tube. We studied that there is an X-ray tube which will produce the X-rays with the help of 150 kilovolt of electricity, which is giving energy. Now this energy is utilized to produce X-rays. Now, so that's how an X-ray production was happening, and we are getting the X-rays which are being emitted from the X-ray tube. Now there is a X-ray film. Now this film is usually, see what color it is. It's almost white color or the bluish in color. So it is usually white or bluish color X-ray tube, X-ray film. Now whenever the X-ray goes and hits this film, see it turns black. So the X-ray film turns black. Now this is how the change in the color of the X-ray film happens, and the entire X-ray can be turned into black color when there is complete exposure of this film. Now, imagine if there is a person standing in between. Now, what will he do? Now, he will stop some of the X-rays. It will stop some of the X-rays from reaching the film. So, this X-ray tube, so this person who is standing in front of the X-ray film is stopping some of the X-rays from going and hitting the film. So, what will happen? It will not become as black as it was before. So we saw whenever the X-ray is hitting the film turned black. But whenever the X-ray is being hit by the X-rays which are passing through the human body or anything in between, it will not turn as black as it was before, because now it will not allow all the X-rays to pass through. So that's how an image is formed. Now one more thing that we have to understand here for how an image is formed is uh, not every structure will allow same amount of the X-ray to pass through. If there is a bone, it may not allow any X-rays to pass through it. So it will not allow any X-rays to pass through it. So the film will remain white. Now, when we see lung, which is filled with air, it is containing air, it will allow most of the X-rays to pass through it. So it will turn the film more black. So this is what we have to remember. Anything that allows the X-ray to pass through it will turn the film more blacker. Anything which will stop the X-rays from passing through it will turn the film white in color. So that is the principle of X-ray. Very simple. Now, we know that the bone will stop the X-rays maximally because it is a denser structure. So for our simplicity, what I'm telling is that anything which is very dense will stop the X-ray maximum. Okay, so bone is dense. If you compare to bone, soft tissue is less denser. If you compare to soft tissue, water is less denser. So what did I tell you? So bone is very dense. If I compare to bone, soft tissue is less denser. If I compare to soft tissue, water is less denser. If I compare to water, fat is less denser. And compared to fat, air is very less denser. Compared to bone, any metal will be more denser. So remember that the difference between the soft tissue and water is very less. So usually we cannot differentiate these two. Okay, usually we cannot differentiate these two. So what are the densities that we see in a chest X-ray? Very simple MCQ. We know that metal, bone, soft tissue and water, fat and air. So how many densities that we can see in a chest X-ray? It is 1, 2, 3, 4 and 5. And what are these 5? The metal, the bone, the soft tissue and water, fat and air. Now these densities, when it comes to a CT, in the CT imaging, we can even quantify. Okay, anything, we have two values. One is a quantitative value. One is the qualitative value. Okay. one is a qualitative. So when we say someone is fat, fatter, fattest, okay, this is the qualitative value. So it doesn't have a particular value. But when I say he is 80 kgs or 90 kgs or 100 kgs, this is the quantitative. So qualitative doesn't give any numerical value to us. It will give us the quantitative will give us the numerical value, whereas qualitative will give us an idea of how denser the structure is what we understand in the quantitative values. Now, what we have to understand here is that X-ray is a qualitative imaging, whereas a CT is a quantitative imaging as well as the qualitative. Okay, qualitative is anything which can differentiate things, is a qualitative quantity. Whereas when I can tell how much is the difference based on a particular value, it can give a numerical representation. Now we call it as a quantitative study. Now, CT is a quantitative study, and I told you we have metal, then we have bone, then we have soft tissue and water, then we have fat, then we have air. So these are the densities that we can differentiate in an X-ray. But if we see the quantitative values of this, the plus 1000 Hounsfield unit. Hounsfield unit is a value that we give in the CT. I'll explain you better when I talk about the CT. Whereas minus 1000 is a value of air, and water, it is usually 0. Okay, water is usually 0. 20 to 40 is a soft tissue. Fat is around minus 100. Okay, so these are the values that we have to remember. Okay, so this is the value that we have to know. This is the quantitative values of different structures in the body. Now, similarly, these things will be differentiated. So because the difference between the soft tissue and water is very less, around 20 HU, we cannot differentiate these two separately in an X-ray. So in an X-ray, these two things as looks as a same density. Whereas when it comes to fat or air or bone, very high difference is there. That's why we see it. Now let's see if this is the film. As we see, wherever the bone is there, the film remains white. The remaining area, the film is remaining black, because this is just a bone I have kept in the middle of the path of an X-ray. It is stopping the X-ray, making the film more whiter compared to the rest of the places. Now, this is a stomach, and this is the patient standing. Whenever patient is standing, the fluid and the debris in the stomach will be settled down. The fluid and debris will be settled down, whereas the air will be present on top. The air will be lifted upwards. Okay, the air is lifted upwards. Why? Air is a lower denser structure. That's a normal nature of air. Air always, or anything which is light, always try to be on top. Anything heavy, it try to go bottom. Heavier structure, the food and the fluid and the food will be bottom, whereas the air will be present on top. So now what happens? Now if I pass an X-ray through this, what will happen? The fluid and the particles, the debris, will stop most of the X-rays from passing through it. Understand that? It will, because it is denser structure, whereas air will allow most of the structures to pass through it. Okay, air will allow most of the things to pass through it. So because of that, wherever the food debris was there, it is becoming more and more whiter, because the X-rays not hit the film remains more whiter. Okay, so that's what happens to the X-ray film. Now, if you see the top of the film, the stomach, that is the fundus of the stomach, it will have air on top of it. Now, because there is air on top of this in the fundus of the stomach, it will allow most of the X-rays to pass through it. Air is less denser structure, it is allowing more, so it will remain black. This is why in an erect X-ray, I told this is a patient who is standing. In any erect X-ray, if you see the fundus of the stomach, it will turn black. So that's what we see in a erect X-ray. Okay, now next, if you see the factors that determining the brightness. Now see in this image, I have taken the bottle and filled the bottle with air. Okay, now I've taken the bottle, filled the bottle with air. Now what happens? It will allow most of the X-rays to pass through it, except the lid part. The lid is more denser. The lid will not allow most of the structures to pass through it, but the bottle is containing only air, allowing most of the air to pass, the X-rays to pass through it and hitting the film. So it has made the film appears more blacker. Now see the second image. I have filled it with water. Now what happens? The water will stop more X-rays. Water will stop more X-rays than air. Now what happens? The number of X-rays, if I send 10 X-rays here, almost 9 was reaching here. If I sent 10 X-rays here, now only 5 of them will reach. So it remains more and more whiter. Now imagine if I have filled this in, if I replace this film, if I have replaced this the bottle with a solid structure like a bone, it will stop most of the X-rays from hitting the film. So the film will appears white. So this is how the different structures will be responsible for different imaging quality that we see. Now, one more thing that I already told you, the different structures that are seen in an X-ray are these things: air, fat, fluid and soft tissue, bone and metal. Even the fat will come here at minus 100 HU. So these are the structures that we see here. Very important to remember. So this is what tells us that density is one important factor which is responsible for the brightness in a image. So we see the metal appears whiter, air appears blacker, in between all are in the different shades of gray. But the second thing is the thickness. Now imagine if I sent 10 X-rays to pass through it, it allowed 9 to go through it. Now imagine I take the second scenario where I have taken 2 glasses of water. Now if I send, it will stop one X-ray. The second glass might stop 1 or 2 X-rays. So at the end, initially it was 9. Here it might be 8 or 7 X-rays which are going through. Similarly, if I take the third example with 3 bottles, now what will happen? Each one might stop 1, 1, 1. So it might be, or 1 or 2, each might stop. So if this is allowing 9, this might allow 8, this might allow only 7. So see, as I increase the thickness, the number of X-rays hitting the film reduces. And we know that the number of X-rays hitting the film is directly proportional to the blackening of the film. Now, thicker the structure, brighter it will appear. That's what we tell. The third thing that I tell is the duration of exposure. So what happens in the duration of exposure? Now, imagine now there is a X-ray film, there is a can filled with water. Now or it is a bone is present here. I allowed 10 X-rays to pass through it and only 7 reached. Now what do I do? Now if I increase the time, now if I increase the time here, okay, if I increase the time now, what will happen if I increase the time? If I increase the time here, uh, there will be more and more X-rays will be going and hitting the X-ray film, and now the blackening will increase. Now there is increase in the blackening of the film. There is increase in the blackening of the film, and the film turns blacker. So this is what we see here. Okay, so this is what we see. The blackening of the film is what we see here. Now, this increase in the blackening is because if at 1 second, if 7 X-rays are hitting, when I expose the same amount of X-rays at 2 seconds, the 14 X-rays are hitting. Now, what will happen? At 3 seconds, there will be 21 X-rays are hitting. So there is more and more number of X-rays that are hitting the film. Now, this is what is responsible for the blackening of the film. So the second thing that we have to understand is the brightness is directly proportional to the density and the thickness. divided by the duration of exposure. Okay, so this is what is deciding the brightness. So we saw the three factors: increase the density, increase the thickness, and decrease the duration of exposure, then the brightness increases. So this is the principle behind the brightness of an X-ray. But most important thing out of this that we have to remember is the density. Density is the most important thing that we have to remember, because in the body there are different dense structures. Okay, so this is how we got an X-ray. Now you look at this image, the concentrated this image. We have a liver here, we have a spleen here, we can see a fundal gas shadow here. Okay, we have the liver here, we have the spleen here, we see the fundal gas shadow here. Okay, now this is how we can see the liver, the spleen, and the fundal gas shadow. See, this is liver, this is the spleen, this is the fundal gas shadow. I told you why there is fundal gas shadow, because in an erect film, if you see your stomach, the debris and the fluid will be settling down, the gas will be settling at the fundus. So this is why I see the fundal gas shadow. Okay, now why do I see the spleen so bright? Why do I see the liver so bright? Because these are the soft tissue structures which will not allow the X-rays to pass through it. Now, if you compare to the soft tissue to the bone, bone is looking more brighter. Why is it looking more brighter? Because bone is attenuating more and more and more X-rays. That's why the bone is appearing brighter. Now compare these two structures. Now again, this what are the structure that we are seeing is stomach and the great vessels. Why are they appearing brighter? Because they are soft tissue structures. But if you see, compare this the soft tissue, you can also see that there is vertebral bodies here which is looking slightly brighter compared to that of the soft tissue. Now this is again because the bone is more denser. Now one more small factor that I have to tell you which is responsible for all these is the distance of the structure from the screen, which I will explain eventually. You just have to patiently listen to this. Now look at this, look at this image, what we are seeing now. Now in this image we saw the liver here, we saw the spleen here, we saw the fundal gas shadow here, we saw the heart, we saw the aorta, and also observe that this is the aortic knuckle, and what's going down here all the way to the abdomen is the descending thoracic aorta. So this is the aortic knuckle, this is the descending thoracic aorta. Now immediately next to it we can see a line, this is the vertebral line, the vertebral body line. So this is the vertebral body line, this is the aortic knuckle, this is the descending thoracic aorta. Okay, so this is how we can see different structures. Now one more thing we have to observe is there are the ribs. Now this is how the rib is present. This is the first rib, then comes the second rib. Now if you see, observe clearly, we can see that this is the one part of the rib, another part of the rib is coming like this. If you see at this part, we can see this part of the rib and ending only here. It is not reaching the midline. Whereas if you see the posterior part, it is almost reaching the midline. Now, whatever which reaching the midline, anything that reaches the midline, anything that reaches the midline is the posterior rib. Okay, anything that reaches the midline is the posterior rib. Anything that doesn't reach the midline is the anterior rib. Remember that anterior rib doesn't reach the midline, posterior rib reaches the midline. One more thing that if I have to tell you the difference between anterior and posterior rib is that the posterior rib is more horizontal, whereas the anterior rib is present more oblique. Okay, in a PA chest x-ray. So these are the things that we see in a chest x-ray. So this is how it usually is seen. Now one more thing that I have to tell you is that out of anterior and posterior rib, it is a posterior rib which is more denser. Okay, posterior rib is more denser, anterior rib is less denser, and if I press it, if I press the anterior rib, it will break. It is very brittle. So that is the density of the anterior rib, and this is the posterior rib is more denser. But if I see this image, you can see both of them almost the same density. Explanation through this I will tell you. In this, it is because anterior rib is closer to the film. Why is this happening? I'll be explaining it soon. Just be patient and listen to this now. Okay. Now, also we can see few other structures here. So what is the structure that we are seeing here? This is the lung. Okay. What we are seeing here, whatever is appearing blacker is lung. Why is lung appearing blacker? Because lung is containing air. Now lung is containing air which will allow most of the x-rays to pass through it, except few x-rays will be stopped by the interstitium in between. But other than that, it's only air. So that's why most of the x-rays pass through it. So it will make the film more and more blacker. So that is about the chest x-ray. Okay, so this is about the chest x-ray. We can see the lung, which is appearing blacker, and we can see the spleen, we can see the liver, and then we saw the lung, we saw the heart, we saw the aortic knuckle and the descending thoracic aorta. And if you see here at the midline, we can see a blacker structure which is coming and bifurcating. Now, this is nothing but the trachea, and the tracheal bifurcation is what we see here. Trachea and tracheal bifurcation is what we see here, and this is the trachea. Why do I say this is trachea? Because it's two straight lines which is denser, but in the middle we can see air density. So this is why we say this is trachea. Now, other than this, we can see the clavicle here. We saw the vertebral bodies in the midline, and then we have the scapula here, and then the humerus here, and the humerus is on the outside. So this is how our image looks. So this is the relatively dark area, is an air-filled area, is a lung, and we see this soft tissue density area, moderately gray area. This is heart. And always imagine that whenever we examine a patient, so this is our perspective. You are the doctor, and this is the patient looking at you. You're the doctor, patient is looking at you, and that's when we examine it. Okay, just 1 minute. I'm just getting an emergency call. Sorry for the interruption. It was an emergency call from the hospital. Okay, so what exactly happens here is that there is a doctor, there is a patient. So whenever we examine any patient, we have to imagine that the you're looking at the doctor, and there is a patient here. Okay, you're looking at the doctor. Okay, the patient is looking at the doctor, and we are examining. So whenever a patient is looking at me, which is his right? Whenever a patient is looking at me, this is his right and this is his left. So that's how any imaging in radiology is. In any imaging in radiology, you have to imagine that patient is looking at me, and that means this is his right, this is his left. Very simple. A patient is standing in front of you, and that's what is the image. So this will be your right and this will be your left, and that's how we label the image. So we know that if this is the right and this is the left, heart should be towards the left, and this is normal. If the heart is towards this side, it is dextrocardia. Very simple it is. So any image, unless there is a label here, okay, usually there will be a label. Unless there is a label, see here there is a label. We can see one label here, left. Okay, this is a label. Unless there is a label, unless and otherwise it is specified. If there is no label here, also we know that this is the left and this is right. But if in case there is no label, if in case there is a label which is telling that this is left then we have to go with the labeling, because we don't know what the technician has done. So main thing is we have to see that which is right and which is left, and then only we have to decide the what is the condition. Now similarly, if there is no labeling, we know that this is right. And then if there is dextrocardia, the next thing that I have to see is where is the fundal cast shadow, where is the spleen, and where is the liver. The larger one is usually the liver, the smaller one is usually the spleen. If in case you see the fundal cast shadow here, you see the spleen here, you see the larger liver here, then we have the diagnosis of the situs inversus. Okay, then it is situs inversus. Okay, so if there is dextrocardia, always look for the abdominal contents. So that's how we diagnose the situs inversus. Now this is a lateral view of chest X-ray. So again, we can, if you see this lateral view of chest X-ray, we can see the vertebral bodies. And if you observe this, as we go downwards, the vertebral bodies will become more and more blacker. Now this is called as the spine sign. Okay, this is called as a spine sign. It's not exactly the vertebral body which is becoming the blacker. What is happening? There is more soft tissue here, there is less soft tissue here. So as I go downwards, the more and more X-ray is passing through the spine. So the X-ray is passing through the lung, because the lung is larger at the lower part. The body habitus might remain the same, but at the level of the shoulder, there is more and more soft tissue is at the level of the shoulder. But as I go down, the amount of soft tissue reduces, but the lung volume increases. So that's why it will allow more X-rays to pass through it. That is why the lower spines are appearing blacker. So this is nothing but, this is called as the spine sign. So this is called as the spine sign. Upper part, there is more soft tissue, so it is appearing more brighter. Now imagine that this area is also appearing whiter. Okay, this area is also appearing white. Now if this area is also appearing white, what does that tell? It tells us that the lung is replaced by a soft tissue. Now what does this tell? Lung is replaced by soft tissue means what? The lung is replaced by some soft tissue means lung is replaced by a tumor, or the lung is replaced by consolidation, or there may be collapse. So there is something which is denser in this area where there was normally air. So that's when we see this, the spine sign is very important. That is, the spine is appearing more and more blacker as we go downwards. Now here is the heart, and this is what tells us that heart is present anterior mediastinum, the posterior mediastinum there is no heart. Now here we have to follow one principle, is that the principle of shadow. Now there is a ball here and I keep a film here. So imagine there is a source here and the source is coming and hitting the film, and now we got an image which is almost the same size of that or ball. Now imagine if I keep a film behind here, now what happens? The same X-rays will go and hit the film at a larger area. Imagine the size of the ball now. It is appearing very large. So what does that tell us? As the structure that we are imaging is farther from the film, the size increases. And one more thing, what happens is, if you see the sharpness here and here, the closer, whenever it is closer to the structure, it will be appearing more sharper. As I go away, it will become more and more blurred. Now this, I always give an example. Keep your hand on the table. Now keep your hand on the table. The light source is coming from top. And your hand is on the table. Okay, the light source is coming from top. Your hand is on the table. The light source is coming from top. Now as I move away, my hand away from the table, you see the shadow that is formed on the table. It becomes more bigger and bigger, and it becomes more blurred. So as I move the hand away from the table, it becomes more bigger and bigger and becomes more blurred. Okay, it is becoming more and more blurred. So that's what we see in case of a X-ray, that when we do an X-ray in a patient. Okay, now why I tell you this is, now imagine if I take an X-ray in which the X-ray tube is kept behind the patient, and send the X-ray anteriorly. Now The heart is present anteriorly, the film is here, the heart is closer to the film, the size of the heart is same as that of the heart, and it is more sharper image. Now imagine I do the other way around. I keep the tube here, and now if I pass the x-rays, now what will happen? The x-ray will be magnified, the larger size of the heart is seen here, and the image is blurred. Now whenever I keep the tube here, the X-ray is passing from posterior first, then anterior. So we call it as PA weave. Okay, first it is going posterior to anterior weave. It is called as PA weave. But if I keep the X-ray tube here and pass the X-ray like this, now it is going from anterior to posterior. It is called as AP weave. Very simple. There is two weaves that we have to remember. That is the PA weave and the AP weave. Now, when do I say it is a PA weave and when do I say AP weave? Very simple. If it is going from posterior to anterior, I call it PA weave. Anterior to posterior, it is called as the AP weave. So this is the difference between the PA and the AP weave. Now, this, whatever we are seeing here is a erect chest X-ray. Whenever possible, we take a PA weave. But the problem is, whenever I take a PA weave, I have to make the patient stand. Now, why is this? Now, how do I take a PA view? Now, you ask the patient to stand. If you observe me, you ask the patient to stand. You ask the patient to hold his wrist on his waist. Okay? Hold the wrist on the waist. Move the elbows anteriorly. Okay? Hold the wrist on the waist. Move the elbow anteriorly. Why am I doing this? Because when I move the elbow anteriorly and holding it on the wrist, the scapula, which is present in the medial aspect on either side of the spine, will move away and make space. Okay, it will move away and opens a window through which you can see the lung. Okay, we can see the lung through this open space, which is created by the scapula, which is moving outwards. Now, this is what we see in case of a PA chest X-ray. Now, this is how we do a PA chest X-ray. So, after holding the hand on the waist, folding the hand anteriorly, folding the elbows anteriorly, we are moving the scapula outwards. We get an open space. That's why we are seeing most of the scapula is outside the lung field. Most of the scapula is outside. If it is an AP weave, I usually don't want the scapula inside. Why I don't want the scapula inside? Because if the scapula is inside, if there is a lesion, which will be obscured. Okay, in the lung, in the black lung, if there is a white tumor, which will be a white, it is clearly seen. But if there is a scapula which is covering, even scapula looks whiter, we cannot differentiate it easily. So that's why I want to move the scapula out. So I ask the patient to hold the hand on the waist, fold the hand anteriorly at the elbow. You push the elbow anteriorly, and this is how I stand. And in a PA view, I keep the film on my chest. Why do I keep the film on my chest? Because whenever I keep the film on my chest, the heart is closest to the film. When the heart is closest to the film, the heart size remains same. Okay, heart is not magnified. We don't want the heart to be magnified, so heart is kept closer to the film. That's why I want a PA film. So why I want a PA film? Because heart should be kept closer to the film. And the second thing that I have to tell you is that I'm holding the hand on the waist, pushing the hand anteriorly. One more thing to keep in mind. What is helping us here to diagnose? The blackness of the image. What is responsible for the blackness? The air inside the lung. So we want air inside the lung. Okay, we want air inside the lung. So that's what is responsible for the blackening of the image. So blackening of the image is because of the air inside the lung. So how can I increase the air inside the lung to make it a better imaging platform? So what I ask the patient is take a deep breath and hold. So what the patient does? Takes a deep breath and holds. Along with that, holds a hand on the waist and pushes the elbow anteriorly. We get a beautiful image of the chest, of the lung, with no scapula overlapping, the scapula pushed outwards. We get a clear lung, which is appearing blacker because of the air. Now, if I do imaging on this, if there is a tumor, a clear cut image of the tumor can be seen. So this is what we see in case of a PA chest X-ray. Now, Do I want to do a AP chest X-ray? I don't want to do an AP chest X-ray. Why? One, because the heart will look larger, and it will look more blurred. So if the heart is looking larger, it is covering more lung area. So less lung is covered. And also, this is one reason why I don't want to see a PHS. The second thing that I told you is as I keep the source, the imaging object closer to the film, it becomes more sharper. As I take away from the film, it becomes more less sharper and less darker. So now less brighter. So what one more thing what we have to understand here is that one is the magnification factor. Second thing is, as I showed you example of the shadowing, as I go away from the film, the shadow becomes lesser and lesser brighter. So that is very important. So as I keep any structure away from the film, it becomes less brighter. Now if I keep a rib closer to the film, it becomes more brighter. If I keep away from the film, it becomes less brighter. But by convention, we know that posterior ribs posterior ribs are anyway brighter, posterior ribs are anyway denser, so it will anyway look brighter. But anterior ribs are not denser, it's less denser, so it will not look that brighter. So appreciation of anterior ribs is difficult in a chest X-ray. So what do I do? If anything which is not brighter, what I can do, I can keep it as close as to the film so that it appears more brighter and more sharper. So what I see is, whenever I see this anterior rib, that means that this image is a PAV. Why? Because anterior rib is closer to the film, so it is clearly seen. But in any APV, we will not see the clear-cut anterior ribs. Remember that. If you don't see clear-cut anterior ribs, that means that the imaging is done. The imaging is done mainly by a AP view, because in a AP view, the X-ray tube is kept anteriorly, the film is kept posteriorly, so the film is away from the X-ray from the ribs. Now, the chest X-ray views, we have this. Whenever I keep the film posterior to the patient, then send the X-ray from anteriorly, this is called as a AP view. Okay, now so this is how the chest X-ray imaging is done. Now, next topic that we have to go is a systematic approach to any chest X-ray. Okay, the main thing that we have to see here in the systematic approach is the correlation between anatomy and the normal shadows. Okay, so mainly we do what we do is we have an approach pattern, that is ABCDEF pattern, or we can do in our own way. Okay, so what I showed you previously was, this is the trachea which will bifurcate here with the carina. This is the heart, we have the liver, we have the spleen, fundal gas shadow. There are bony structures, multiple bony structures. Then we have subcutaneous shadow, subcutaneous tissue. Here there is subcutaneous fat, then there is subcutaneous muscle. So these are the different structures that we see. Okay, so this is the trachea, this is the heart, this is the liver, this is the spleen. Now what we can do is, we can do two approach. One, we can start from outside inwards. So we can see the skin here. Below the skin, we can see a small layer of black area. So this is nothing but the fat, less denser tissue. Deeper to the fat, these are the soft tissue density. Okay, it is more whiter. Here we can see air with some interstitium, air with interstitium in the lung, which is appearing blacker. Pure soft tissue, liver. Pure soft tissue, spleen. Air in the stomach. Then we can see here is the heart and the aortic knuckle and the aortic shadow. And then we can see the bones, multiple bones we can see. So this is how I can approach. I can see multiple structures. Now before doing, so this is how we see the airways. Okay, and then we can see bone and soft tissues. So the bone is there, and then we can also see the anterior bone, posterior bone, the clavicle, the sternum, the vertebral bodies, different bones we saw. Then we can see the cardiac silhouette and mediastinum, and the descending thoracic aorta. So see the heart. Also, whenever I see the heart, we can measure the distance between the heart and the lung the heart is usually less than 50% of the lung area. So that means it's normal. If it is more than 50%, we call it as cardiomegaly. More than 50% is the width of the heart compared to that of the lung, then we call it as cardiomegaly. Now, this is how we approach the uh, uh, the imaging of a chest X-ray. And we can see that this is the diaphragm, level of the diaphragm, because deeper below that is the abdomen. Here now it is the liver, here now it is the spleen, here it is the stomach. Very simple it is. Here also, in this image also, we can see that this is the heart, this is the vertebral bodies. But we can see here one diaphragm which is continuous from anterior to posterior, the other diaphragm which is stopping at the level of heart. Remember that whatever stops at the level of the heart is the left diaphragm. Whichever continuous from anterior to posterior is the right diaphragm. It is the right diaphragm. So these are the two diaphragms that we are seeing in this image, which is similarly right and left is seen in case of a APV as well. Now also we have to remember that whichever diaphragm is appearing higher in this image, whichever is diaphragm is appearing higher, okay, what does that tell us? That diaphragm is away from the film because it's zoomed up. Okay, so this diaphragm, the left diaphragm is appearing larger. So this is a left decubitus X-ray. So it is a left lateral decubitus X-ray. So left lateral X-ray, not decubitus, left lateral X-ray. Why do I say? So how the nomenclature goes is that if this is the X-ray tube, this is the right of the patient, this is the left of the patient, and if the X-ray is going from the right to left, instead of telling the X-ray is going from the right lateral to left lateral, we are just ignoring the first part and we are just telling the left lateral chest X-ray. Okay. So if I say left lateral chest X-ray, that means that the X-ray has gone from the right side through the body, then to the left side. This means that the left lateral chest X-ray. Whenever I say left lateral chest X-ray, that means that X-ray is going from the right to left. That means that right diaphragm is away from the film. That means that right diaphragm will be appearing larger. Okay, it's appearing larger. Similarly, if I'm telling right lateral chest X-ray, that means that X-ray is passing from the left to right. That means that the left diaphragm is appearing larger, so it is appearing higher. So in this image, we know that this is the left diaphragm is appearing larger. So that means that X-ray is passing from the left to right. Means that this is a right decubitus X-ray. If you have any doubt, you have to approach me, because this is it's a very simple topic, but if you don't concentrate, it's a slightly difficult to understand. So that is about the lateral decubitus the lateral decubitus X-ray. Okay, so the next thing that we have to see is that the costophrenic angle. So this angle here is called as a costophrenic angle. Normally it is containing air, but whenever there is fluid accumulation, it will come and accumulate here. So if there is blunting of this sharp costophrenic angle, that means that there is pleural efficiency. Similarly, we can see the posterior costophrenic angle. Along with the right and left costophrenic angle, we can have also the posterior costophrenic angle. Then we saw the gastric bubble with internal gas, and then we have the horizontal fissure, which is not seen here, but that's how the horizontal fissure will be present. And along with the horizontal fissure, there will be a vertical fissure dividing the lung into upper lobe, middle lobe, and lower lobe. I'll go through the fissure in detail when I'm talking about the collapse. Just remember that this is how the fissure runs. Okay, this is how the fissure runs. Now, this is how the multiple lobes are present. So here is the upper lobe, and here is the middle lobe, and here is the lower lobe. If you concentrate clearly, the lower lobe and middle lobe collapse, but there is something called a Silhouette sign, which will help us to differentiate a collapse of a lower lobe and the middle lobe, and that's how we differentiate. But when we see on the left side, there is no concept of middle lobe, but here it is made up of upper lobe and the lower lobe, involving almost the entire of the chest X-ray. The technical quality of any X-ray initially when we have to see the technical quality, because if the technical quality is not good, the imaging interpretation also goes bad. So that's why technical quality of a chest X-ray is very important to understand first. So PA is always superior to AP view. As I told you, I always want a PA view because it gives the right size of the heart. It gives a smaller heart. It gives a wider open lung space so that we can see the lesions there. We don't want a AP chest X-ray. Ideally, we don't want an AP chest X-ray. Okay, so that is important for us. Now, when do I do an AP chest X-ray? When I can't make the patient come to the X-ray department, ask the patient to hold the waist and bend anteriorly, bend the hands anteriorly, and take a deep breath. So if I can't do any of these maneuvers, then I ask the patient to take a AP chest X-ray. The factors affecting the technical qualities include the rotation, inadequate inspiration, and suboptimal penetration. So first thing is I want to get a PA chest X-ray. I don't want AP chest X-ray, but I told you when do I do an AP chest X-ray? When I can't do a PA chest X-ray, I do an AP chest X-ray. But when I do a PA chest X-ray, then I have to see these following parameters. I have to see the rotation, the inspiration, and the penetration. Very simple. The rotation is nothing but either patient has rotated on right or left, anterior or posterior, or along the central axis. So whenever this rotation happens, so the right and left rotation won't happen much. So usually we don't bother much about AP because AP is very bad images. But in PA film, we always see these things because PA gives a very good picture, and that's why we bother to see in that. So the right to left rotation, all that can be clearly seen. What rotation is very difficult to understand is the rotated patient along the axis. Okay, along the axis. Now if the rotation is along the axis, now what happens? So that's the only important thing that we need to know. So this is what happens whenever there is rotation. So in this image, so this is the spine, this is the clavicle. So see what has happened. The distance between the clavicles on both the side is difference. Now one side is more distance, other side is closer. Why this happens? So see this image. So normally when it is parallel, what should happen? The spine should be in the center, that both the clavicle should be equidistant from the spine. Now what happens? I have kept the patient sideways. Now what will happen? Whichever side is more anteriorly, that will come more medially. Okay, it will come more medially. Whichever is more posteriorly is coming more laterally. So what happened? The distance will increase. The distance will increase in whichever side the rotation is happening. The distance will increase whenever there is a rotation. Now, whenever the left is anterior, the distance of the left clavicle will be lesser from the spine. Now, for example, in the previous image, okay, in this image, now what has happened? The distance of the left clavicle is lesser. That means that the left side is come more anteriorly. Okay, the left side is present more closer to the film. So whichever side is more closer to the film, the distance between the medial head of the clavicle and the spine is reduced. So whenever I say the rotation, now what rotation has happened here? The right side has come anteriorly. So whenever the right has come anteriorly, the left clavicle is present close to each other. So that's what we have to remember. This is the only point we have to remember whenever we say. Now, one more thing what happens is when this happens, the lung which is come anteriorly will appear more blacker. Lung which has come anteriorly will appear more blacker. So on the right side, the lung appears more blacker than the left side. So this is very important to understand to interpret it. So whenever I see the clavicles has become narrowed, that means that side the lung is appearing more brighter. It should not look more darker. That is the important concept of rotation, which will help us to interpret various things, which will come to that. Eventually, the second thing that we have to see is whether it is a full inspiration or not. Very simple to see. We know that this is anterior rib. So we have first, second, third, fourth, fifth, sixth, seventh, eighth. So if you see eighth rib cutting the uh, the diaphragm, or we say 6 to 8 anterior ribs cutting the diaphragm. It's okay, 6 to 8 anterior ribs. Okay, it can be even 6 ribs also, no problem. Or if it can be cutting the diaphragm, then it is called as good inspiration. 6 to 8 anterior ribs should be present when you reach almost in the mid clavicular line. When you reach almost here, 6 to 8 anterior ribs should be cutting the diaphragm. That's when we say full inspiration. Less than 6, it is not a full inspiration. Okay. Similarly, we can see even the posterior ribs. So this is the posterior ribs. So if you see posterior ribs, so if it is 8 to 10 posteriors, if you see, then it is good inspiration. If it is less than that or 8 or less, then it is called as a poor inspiration. So 6 to 7 anterior ribs and 9 to 10 posterior ribs is what we remember. For simplification, we can just remember anterior ribs 6 to 8, 8 to 10 is the posterior ribs, multiples of 2. Okay, 6, 8, and 10. So 6 to 8 is anterior ribs, 8 to 10 is the posterior ribs. That's what give us the good inspiration film. So in this, what has happened, only 8 posterior ribs are present. So it is a poor inspiratory film. See how bright these things are looking. They're not looking blacker, they're looking brighter. So similarly, if I see this image, now it is fully inspiration. It is looking more blacker. Even if a small lesion is there, we can clearly see. So that is about the inspiration. Okay, so that's the second thing that we should see here. Now, third thing is the penetration. Penetration is when we say a good penetration. This is a good penetration actually. So what happens here? The vertebral body here at the retrocardiac area should be barely seen. It should not be very obvious, or it's not like it should not be seen. Here it is not seen at all, whereas in this image it can be it is very dark. You can see that it becomes more and more blacker. So this is the too much of the penetration, this is too less of the penetration. In fact, here we can see the vertebral body very clearly, but this image is not proper, we cannot see in this. But otherwise, if you see vertebral body very clearly, or if you don't see at all, then it is bad penetration. Barely we should see the vertebral bodies in the retrocardiac area, then we say it's a good the penetration or exposure. So this is how we see chest imaging. We look for rotation. Patient, we should look for mainly the rotation along the central axis. Look for good inspiration, look for good penetration. Then the technical, once the technical aspect is very clear, then start seeing the from the soft tissue, then the bone, then the lungs, then the heart. Like this, we keep on seeing the different structures. So this is one more thing that I had told you, the principle of magnification and the blurring of the border. So this is one more thing that I want to tell you. Whenever I do a PA view, we know that the scapula is out of the lung field, whereas the AP view, the scapula is inside the lung field. And also in the PA view, I told you we hold the hand on the waist. So what will happen? The clavicle will be lifted up then, and so the clavicle is more vertical than the AP view, in which it is more horizontal. Okay, the third thing that happens is the ribs. I told you, the in APV only posterior ribs are seen, anterior ribs are not seen. But if you are seeing anterior ribs, that means that it is a PA view. Also, we have seen that the sternum is clearly seen in case of a PA view, because sternum is close to the film, whereas the vertebral bodies and the spine is clearly seen in an AP view. And if you see the fundal gas shadow, it is seen in case of a PA view. Now, this is how we differentiate a chest X-ray, whether it is a AP or PA view. Only horizontal ribs are seen, only posterior ribs are seen, which are horizontal, and then the clavicles are more horizontal. Clavicles are more vertical, and anterior ribs are also seen. So this is the PA view, this is the AP view. Also see the fundal gas shadow, seen here, not seen here. And also we know that the heart is smaller in case of PA, whereas larger in case of AP view. So this is how we interpret a chest X-ray. So overall, this is how you interpret a chest X-ray. So we saw how to approach a chest X-ray. If you guys have any doubt, you can ask now. And we have seen a clear-cut approach of a chest X-ray. There is no doubt now. So all the points are very clearly told. And also, if you have any doubt, you can ask me anytime. You can approach me anywhere. You can call me, you can text me or WhatsApp, you can mail me. My email ID is prajwath.rai92 at gmail.com. 8867268669 is my number. Radio Rai .in is my website. So anywhere we can approach me for any of your doubts. Or it's very good that you all have joined, or you are following MedPG. Please keep watching MedPG. It's going to be very useful. The MedPG sir is doing very good job of introducing this kind of curriculum for all the students. It's a must for all the students. So thank you very much. Please let me know if in case there are any doubts. And also thank you. Goodbye until we meet in the next class. Bye bye. Okay, Mr. Pulkesh, can we sign off? Or is there any doubts that I can take? Hello, Mr. Pulkesh, or any host around?